Thank you. Any question from the floor? Okay, Nuno.
This question is to Luís, and first of all, I would like to thank you for the wonderful presentation, because I always learn something from you, because I'm a mathematician and you're a doctor. I love your slides. And in one of your slides, you said something about a lengthy diagnosis, right? And when we were in Euromean and we were discussing the case definitions that would be recommended in Europe, I was just wondering, the length of the diagnosis can have two causes, right? The one part is actually the disease recognition is low. And the second one that is not so well discussed is the exclusion criteria that you have to do it to have the diagnosis. From your perspective, and that's my question, is would you believe that would help not to have the exclusion criteria and you have like suspected chronic fatigue syndrome, and then along the way you actually make a strong case towards that? I think maybe this accelerates the diagnosis, but I would love to hear your thoughts about that.
Yeah, I totally agree with you. The NICE guidelines is interesting. They change from the IOM in two senses. One, you don't need to wait 6 months for a diagnosis, but 3. But more than that, with 6 weeks in adults, in 4 weeks in children, you can suspect a diagnosis. And I'll tell you, as a GP, GPs are not very good at saying you have something. They like to observe the patient for some time until there is a confirmation. So the idea of suspected diagnosis, I think it's very important. And this can facilitate early recognition. The other aspect is about case definition. And I think it's very important that we distinguish research definitions from case definitions. Research definitions need to be very specific, because we don't want to muddle the waters, and then we want results that are reliable. But clinical diagnosis, they don't need to be that specific. So they recognize that people may have comorbidities, and if you're unsure about the diagnosis, you need to treat the patient is there anyway, so you can deal even if the diagnosis is not a formal one of ME, for example, or something else. So I think that we can be more relaxed in accepting the patient for clinical treatment. I think, Nuno, do you have a follow-up question or?
No, just a comment on what you said. It's something about research and clinical. Well, you do recruitment through the clinic, so in a way you need to have some kind of agreement between the two. Otherwise, you take like I'm coming from the infectious disease, tropical disease mostly, and you have convenient sampling. And by doing, recruitment via a case definition that doesn't have like exclusionary criteria, then you ended up with a cohort of patients that you would like to recruit for research, but they actually don't comply. So how would you do that? It's just
right. Briefly, well, not all patients in clinic will be eligible for research. So research can be more stringent for acceptance to research. But there is something else that the IOM has, the NICE guidelines have, is that differential diagnosis has replaced exclusion criteria. Differential diagnosis needs good clinicians who look at a patient, do a good history, physical examination, tests as needed, and this will enable them to come to to answer the question: is this really ME or could something else? So there is this idea of exclusion is less used in clinic. It's more used in research, because in research you want to be very, very algorithm-like, if that makes sense.
There is another question. Okay.
Hi, good afternoon. Yes, good afternoon. Following up from the question from, sorry, I forgot your name, sorry.
Caroline?
One of them, as a carer of someone that suffers from ME/CFS, and the common on all the groups that we're in, one of the big delays comes from the lack of recognition that the person is sick, and it gets parked and thrown onto its anxiety, it's psychiatric, and we don't listen to the patients. And again, my experience is the patients know what they're feeling. A sick patient does not pretend to be sick. And we need to listen to the patients because they know what they're feeling. Even I, as a carer, cannot really say what the person I care for feels. We need to listen. And think that alone will diminish by more than half, if not even more, that we start attending to to care the patient, start early if we listen. And if we make a mistake because we listen, that mistake will still be shorter lived than a person with MS taking 7 years to be recognized, a person with ME/CFS taking 20 years to be recognized and to be helped. And I don't know what we can teach the younger doctors that are coming in, that they listen, and what we can do to the older doctors, that they pay attention, listen to your patient. They're not psychiatric cases, they are ill. And this is for families, this is for long-term friends of the patients. They already have such a burden. We need to listen to them. Thank you.
Yes, I mean, I totally agree. And I thought that was changing. Years ago, we were told to listen to mums about their children because the mum knew the child wasn't well, and you were at your peril if you didn't. And I just think we don't learn, do we? And I think listening takes concentration, it takes time, it can't be hurried. And I think that's what people deserve.
Well, I have here one question about, I don't know if there are anyone in the room with experience on that. Which nutrients can you have more benefits on EM, CSF patients on the practice? I have no experience with that in clinic. Well, what I know about it is that caffeine, tea, coffee, and tobacco and chocolate must be avoided in the afternoon because they prejudice the sleep. And I don't know much more than this in terms of nutrients for the treatment of these entities. So you have another question?
Yeah.
For you?
My question is how to get more severely affected patients into clinical trials. Aha. Well, we're writing a paper. But in broad terms, funding and endless patience. So the funding is important because you have to be able to go to the patient, and that's expensive. So you have to build that into your research grant. You have to build in the amount of time it will take. You have to build in, I particularly have to build in the time it takes to get the samples back to the hospital in London where they're processed and stored. So the NIH historically have been incredibly generous to our project because it costs a lot of money. And then as an individual, and Ella helps me hugely with this, you're trying to make an appointment with someone who can't speak on the telephone, doesn't want to speak on the telephone, but can't. They might go onto their phone, their mobile, intermittently. So you might text and get a response 3 days later. So actually setting up the appointments, you need need a lot of time, so that has to be paid for, and a lot of patience. And you must never get exasperated because people don't mean to cancel the appointment you've made all these arrangements for at the very last minute, but they're just not well enough to go through with it. So I think those are the two important things, the funding and the time and patience. People who have ME are so wanting to take part in studies, particularly the severely affected, because they know how few people do take part. So that's not an issue. And they use a lot of social media. So if you're looking for people to take part in trials and studies, then social media is the way to go.
Thank you, Caroline.
Right, this question, many patients are being recommended alternative treatments like acupuncture and Perrin technique, for which there is no evidence and are often provided by private practitioners. What do you recommend as best practices in these circumstances? That's a good and difficult question. What I would say is that we offer acupuncture in that service in Canada, and many patients were pleased to receive the treatment. But I can't tell you if this was because it was really effective or if the caring that the professional shows to the patient matters the most, and people like that. I don't think there is, I mean, I cannot say A or B, do or don't do. What I can say, I think the patients are entitled to have an opinion, are entitled to discuss with the doctor. I would like to try this one. And on an individual level, I think the doctor can have an open conversation with the patient and make a joint decision about that. Sometimes the decision will be, well, try this one and see what happens. And then if it doesn't work, you stop, and then you can try something else. So I think in the world of little evidence, I think that especially the safe forms of treatment, and some are safer than other treatments, I think there should be some flexibility. Unfortunately, in the private sector, this is not difficult to organize. In the public sector, depending on where you are, it's a little bit more difficult to be able to offer treatments which are not evidence-based. This is a reality that we need to accept and try to change, of course.
Could you speak to the parent technique, please? The parent technique. Parent technique. The parent technique. Maybe Caroline.
Well,
I know many words, but I didn't know enough about it.
I know the guy, and I think I cannot comment on treatment. It's beyond my. It's an alternative form of therapy, and I mean I don't feel that I can comment on that. He's a good guy, though, I think.
Yeah.
Thank you. There are two questions which can be answered maybe together. We have just heard detailed presentations on therapeutic strategies and coordinated care models in ME, CSF, and long COVID from the United States, Italy, and UK, where multidisciplinary clinics are structured pathways already exist. In Portugal, however, there are still no defined clinical pathways or coordinated care programs for these post-viral conditions. Given what you have learned today about best international practice, what are the realistic next steps to establish a coordinated care model in Portugal, and how should lead that process? Should it be hospital-based, university-driven, or supported by the Ministry of Health? It's a very difficult question and very difficult answer. The second question related with it is how to incentivize health professionals to educate themselves according and be adequately capacitated for these patients. how to make that education a public policy and not only a personal choice. I think the answer in Portugal must be a centered process and centered initiative from or the Ministry of Health or from the Direção Geral da Saúde. It is very difficult to do it in another way. Of course, it must be based on in family doctors and the reference for one or two specialized centers on complex diseases, as Luís talked about in his presentation, is a need. But if the initiative is not central, it's very difficult to provide the correct care for those patients. And included in that is the formation, is the training and the education of medical doctors and other professionals for care of these patients. I think we must do the pressure necessary and I think it's best. The better way is to talk with the Diretor Geral da Saúde. So I think I have another question, and I don't know if from the floor. Okay. So there, Nuno. Excuse me, but there are. Okay. Please go.
I just wanted to follow up on some comments that were made earlier about, my name is Betsy Keller, by the way, and I've been doing the 2-day cardiopulmonary test for a long time. And I wanted to comment on some of the statements that were made earlier about listening to people with ME and long COVID and their symptoms. I think that there's something else that you can add to that mix when you have a patient coming to a practice, and those are the more subtle acknowledgments that they have environmental hypersensitivities oftentimes, so keeping the lights low in the environment, bringing them into a waiting area that's not busy and not noisy, moving them out of a waiting area as quickly as possible into a room where they can lie down or at least sit down. And when you do that early on, oftentimes they're surprised and they understand that you understand. And those are not things that take up a lot of time. They can be done pretty quickly, right off the bat. But also just want to reiterate how important it is to be able to confirm for someone who feels terrible, and they have for a long time, that despite the fact that you want to tell them, you don't want to tell them that they had an abnormal response to exercise. I can't tell you the number of times where patients have asked me to go out and talk to their family to confirm that their exercise test results are indeed abnormal, and there's a reason for why they feel that the way that they do.
I agree with you. I mean, I don't have a specific expertise in environmental medicine, but I would refer early to the experts in environmental medicine and there's a very good clinic in Toronto, in Canada, for example, to do further investigations. I think you need to look at multiple potential causes, and of course, environmental challenges. They will be noticed by the immune system, and this can help perpetuate or even initiate illness.
Hi. So I'm Anna, and I'm a family physician and also a long COVID patient. So I've been on both sides of the coin, and I'm having that, at least here in Portugal, I don't know if it happens in the other countries. I think one of the major problems in the diagnosis is that physicians don't know anything about this condition. So we learn nothing about it at university. There's no knowledge about the disease, and as I was saying to my colleague, you can't diagnose a disease you don't know exists. You can't think about a disease when those symptoms don't make any sense to you. So I think there's a huge gap in education, and I think it can start at universities, but we have to teach also physicians that have a lot of years of experience. They still don't know this exists, they don't value. And then it happens that patients say that physicians don't listen to patients. I think, of course, it happens. Physicians don't listen to patients. They have little time, but also, if you don't have the knowledge, you won't think about it. So I think that's, I don't know, maybe the JS, maybe the ministry can start some learning programs or some sort of updating, but it's difficult. I think it's very difficult, but if we don't start at the base of the pyramid, and I loved your presentations about the way things work in UK and how everything is well structured. Here in Portugal, actually, you have a quite organized national health system, and I think primary care works pretty well for a country with little means. But I think we have a good integration with the secondary care. I work on a unit that has worked well in that area, but if primary care doesn't know anything about this disease, patients won't get treatment. Patients won't be properly treated, and disease will get worse. So I think this is a huge thing that needs to be attended.
Well, I fully agree with you, but if, as you said, you have two hats, the patient and the doctor, medical doctor, and so I think medical doctors are trained for having success in their practice, so they avoid the unsuccess. And with those patients, we have many unsuccess in our consultations and in clinics, and medical doctors avoid that, as other professionals in their profession. I think this is also a problem, to train doctors to have some cases who are not successful, and this is part of life. But we are not trained for that in medical schools, and I know what I say.
But I think family physicians are quite used to unsuccessful treatments.
I know it because I do it, but the question is that many of those cases are not, because you are all right, the knowledge of these pathologies is not so good for the...
Yeah, I agree with you. I think physicians don't like the unknown and don't like things they can't understand properly and things that don't have a lot of evidence. That's all true. But I think family physicians are quite used to uncertainty and are quite used to having the patients, even if you can't offer curative treatment, you still have to support them. You have patients since they are born till they'll die. So we are used to not being...
We can be useful in many ways, of course.
But
We must
people-
have time also.
yeah, yes.
Yeah.
That's a
Time, time.
huge problem. I always worked at NHS, and we have a huge list of patients and a lot to attend. So we do preventive medicine and curative, and sometimes the time to listen properly to the patients is very limited. So it's difficult, but I think we have to really focus on educate the physicians, because I think post-infectious diseases weren't taught at all when we were students.
Thank you. Bruno?
Just to connect, and I think Iliana's,
Raise your hand.
Luís' talk and Caroline's talk. I'm just wondering about severe patients. Why don't trying to consider a phase 1 clinical trial only on severe patients, and then connected with the, let's say, average-based evidence. So if you are in phase 1, I think you don't need a lot of statistics, and that's the kind of change in how you report the results. And I'm a statistician by training, but we over-rely on p-values and significance on average effects. And I think if you go towards like a phase 1 clinical trial on severe patients, I think it's more manageable, and actually it's easier to fund because the sample size is smaller. So what do you think about that? So.
Well, yeah, well, I agree with you, but it's challenging logistically to do severely affected trials. Severely affected. Caroline was talking about you need to go to the home to the patients. They are expensive, so there is a funding limitation there, a funding difficulty. But I totally agree with you. Let's design in severely affected and hope we can get some money.
We only have time for one short question. One short question. I'm pressed by the organization, so one short question.
Let's give someone who has a
One.
chance to make a question first.
No, there are. Okay. In the afternoon, we have time to do more.
I can just speak. Yeah? Okay. Hi, my name is Niels. I am a long COVID patient, and I just had a follow-up question. You were speaking about, that there's no official pathway, clinical pathway for long COVID and ME CFS patients in Portugal. And I just wonder if you have any insight as to why there isn't one. Because if you look at, the UK and the Netherlands, 2 countries I happen to be familiar with, I know there are specialized long COVID clinics there. My experience with them has been varied, but still, it exists. So do you think that this is a lack of willingness, a lack of funds, or just a lack of awareness amongst decision makers?
It's a bit of a myth about the wonderful care pathways we have in the UK, because I have to tell you that most people are tearing their hair out.
No, I mean, I have experience with it. I know it's not great, but at least there is one.
There is one, yeah, but it needs a lot of work.
Yeah, agreed.
I think maybe in Portugal there's a real advantage in starting from almost, and not nothing, but almost nothing, because you can look at best practice and you can try to build up, doing it in tandem with people who have the disease, so that also guides how the clinics are set up. And I think you've got a real opportunity here that perhaps we've lost in places like the UK.
Yeah. I just wonder why, decision makers don't seem to necessarily, be acting on this, at least in Portugal.
Okay. So, okay. I'm pressed, so we are going to lunch, and in the afternoon we can maybe have more just have a discussion about questions you have. Thank you.